Okay, well, I have 105, and I am mindful of everybody else's time, so I am going to ask that we start. But I think that I'll begin, especially since we have such a small group, with the folks on the phone and ask you to introduce yourself. I'm going to start with Bonnie. Tell us where you are, who you are, and where you're from, and everything.
Okay. I'm Bonnie Small from Maine Healthcare Association, Director of Quality Improvement and Regulatory Affairs.
Perfect. And how about you, Jeanette?
I'm Jeanette Pitt from Caribou, Maine, professional home nursing and the quality manager here.
Perfect. Thank you so much. So also on the phone is Blake Morphis and Lynn Chase and my State Director, Danielle Hersey, our Med Safety Team Lead, Rachel Crow, and myself, Maureen Leary, and Jeanette and Bonnie. You both know me. So good afternoon, everyone. I guess I will be moderating today's webinar, and I thank you for joining us on the Safe Transitions, a look at QIO data, sources, and reports. I'm really excited to have you here. I hope that our audience grows a little bit, but I'm also really excited to introduce you to some of the regional resources that we often boast about while we're talking to you. Lynn Chase, who is on the line, is the State Director in Massachusetts, but she also wears another hat, as she likes to say. She is also the Regional Lead for Care Transitions here in New England. Blake Morphis, who will be going over the data, is the Manager of Analytic Services at Health-Centric Advisors in Rhode Island. Blake supports various project teams at Health-Centric Advisors via data management, computer programming, and data analysis. As part of Health-Centric Advisors' Medicare QIN-QIO contract and as part of Rhode Island's Healthcare Quality Reporting Program, he provides quality of care feedback reports to all of Rhode Island's acute care hospitals and nursing homes. So before we get started, I just want to go over a few housekeeping items. We are going to record this call, and after the webinar, I will send out details as to how to access the call. I'm not going to mute the phone lines. Our hope is that we really have some discussion about the information that we're providing. But while Blake presents, I will ask you guys to put yourselves on mute just to prevent any background noises or feedback. And you should know that this webinar was designed specifically for the Northern Maine Care Transitions Coalition. We will break, like I said, we will break periodically for questions and comments, and I really am going to strongly encourage you to take advantage of this time in this webinar to ask questions and provide feedback. So with that, I am going to turn it over to Blake.
Okay. Thank you, Maureen, and thank you, everyone, for joining today's call. And I echo that sentiment of getting your feedback, which will be very valuable for us. So with that, I just want to review some of the goals of today's presentations. First, we'll do a quick review of the 30-day hospital readmission measure, and then I'll touch upon the data source that we use for reporting readmissions. And then after that, we will do a deep dive into the hospital report. And as we go through that report, we really want to hear from you what questions you might have and hear what's helpful and what is not helpful. And then at the end, we'll take a look at our community Safe Transitions report, and Rachel Crow will preview the new adverse drug event data that we recently received. So first, let's take a look at the hospital 30-day hospital readmission measure and review some of the concepts that are behind this measure. So while there's many aspects to care coordination, our distal or big picture measure is often reducing the number of hospital readmissions. So let's start by looking at the definition of the 30-day hospital readmission measure, which is the percentage of discharges from a specified hospital that were rehospitalized at any hospital within 30 days. I'd like to take a look at the numerator and denominator for this measure. The numerator is simply a count of the total number of readmissions within 30 days of an index admission. The numerator does not include those who expired, that is, the patient was readmitted and expired during the readmission stay. Readmissions are measured as a readmission to any hospital facility. For example, when looking at data for an example, say Lakeview Hospital, we're not just looking at readmissions that came back to Lakeview Hospital, we look at readmissions that happened at any hospital. One more note is that same-day hospital transfers are not counted as a readmission. For the denominator for this measure, which is simply the total number of discharges from a hospital. However, there's important exclusions to point out that the denominator excludes same-day hospital transfers and expired patients. Let's take a minute to talk about the index admission. The index admission is the first admission to the hospital. Once the patient leaves, a 30-day window opens in which the patient can be readmitted. If the patient does not return to a hospital within 30 days, then they are no longer eligible to be counted as a readmission. If the patient does return, then it's counted as a readmission. Pretty simple, but what's important to know is that once the patient has been readmitted, they are no longer eligible to be counted as a subsequent readmission until the 30 days after the initial index admission. So if a patient is readmitted twice in 30 days, it would only count one time. Any readmission that happens after 30 days would start a new index admission in a new 30-day window. One of the important aspects to keep in mind with a readmission measure is what diagnosis a readmission gets assigned to. We refer to this as the index admission diagnosis. The index admission, as we just talked about, is the first admission. And we're looking to see if the patient was readmitted for any diagnosis within 30 days. So at the bottom of the slide, I have an example. And let's say that I leave the hospital with a diagnosis of pneumonia, and sometime within 30 days, I suffer a heart attack and I return to the hospital. So in this scenario, when looking at a readmission measure, we will assign this readmission to pneumonia, since I originally left the hospital with pneumonia and returned to the hospital within 30 days. We would refer to pneumonia as the index admission diagnosis and AMI as the readmission diagnosis. I'm just going to take a minute to talk to you about the data source that we use for calculating readmissions. Our main data source for analyzing readmissions are Medicare Part A claims. I want to stress one important limitation of our data is that it is solely Medicare fee-for-service data. So that means that we do not have data on patients that are enrolled in Medicare Advantage. And then the last point I want to make to point out to you is that there is about a 6-month data lag with the data that we're using, and when you're working with claims, they're always subject to change over time, and so even though it's a 6-month lag, there's still a little bit of maturity that would still happen after 6 months. So I just want to make sure that everyone is aware of these points. Okay, so now I'm going to step into the hospital report, and this is the point where we are really interested in hearing from you and your feedback on these reports. And before I get right into the hospital report, I do want to mention that we also produce a 30-day hospital readmission report for nursing homes. And while the nursing home report isn't as in-depth as the hospital report, it does have a lot of the same attributes that you'll see for the hospital report. I know there are a lot of bullet points listed here, and just for reference, I do want to highlight a few items here. First, we provide readmission reports for all hospitals and nursing homes, and we are producing those reports for throughout New England. Second, the reports cover 30-day all-cause readmissions, and the reports are also just based on, as we talked about the Medicare fee-for-service data. I also want to point out that these are just raw claims, and we're not doing any risk adjustment for this data. And let's go into our hospital report. So this is the first page of our report, and the chart in the top left provides the hospital with their 30-day all-cause readmission rate by quarter. And all-cause readmission rate simply means a patient is readmitted within 30 days for any reason. Below this chart are three charts on readmissions that are subset by specific diagnosis categories of AMI, CHF, and pneumonia. These three diagnosis categories are part of the hospital readmission reduction program, and for those specific diagnosis categories, we are excluding planned readmissions. And then up in the top right, we also have demographic data on the most recent quarter of the patients that were readmitted. And at the bottom of this table, I know it's a little small on the screen, we also provide a summary of how many readmissions actually occurred back at the same hospital versus how many readmissions went to another hospital in the state, or they went to another hospital that was out of the state. With that, I will pause here and have Maureen.
So there isn't anybody on the line. I don't think I know, Steve, you have joined us, but has anybody else joined us on the call? So nobody is on the call that I can tell from the hospital side, Blake. So I don't anticipate questions unless Jeanette or Bonnie or Steve, you have a question about this portion. Steve, you missed the introduction, but we really hope that this is as interactive as possible. So if you have questions, please don't be shy. Please feel free to speak up and ask your question.
This is Steve.
Hi.
This is Steve. The information that you have, is it available broken down by hospital to somebody that isn't part of that hospital?
So this is Maureen. No, they are broken down by hospital, but they are confidential to the hospital involved. However, the work that you're doing with Northern Maine Medical Center, I'm fairly certain that Sue will give us permission to share that information with you while we're working on the Squire report together. So your facility and Northern Maine Medical Center will be an exception to this rule, I believe.
Okay. Thank you.
All right. Thank you.
Okay. Maureen, do you want me to just proceed through the slides and...
Sure. Yeah, sure.
When we get to the discussion slide? Okay.
Yeah, except if anybody has, if anybody does have a question in the meantime, we're a very small group, so let's keep it informal and feel free to just talk yourself off mute and ask the question.
Yeah, that sounds good. Okay, so this is the second page of the report, and this is where we also provide readmission data on COPD, stroke, total hips and knees, and we also, as a balance measure, we put in the emergency department as well as observation. So we look to see if the patient maybe didn't get readmitted, but they came back to visit the emergency department or came back under observation. Okay, and I will go on to the next page. So this is our third page of the report, and here we provide some performance information that shows by measure how a hospital has performed within the state for their most recent quarter. And we provide two different rankings. One is based on the latest quarter of data. That is under the section that you see says current right in the middle. And this shows how a facility ranks within the state for their most current data. And so for this example, we can see this facility, I know this is a little bit hard to see on the screen, but this facility had a 23% all-cause readmission rate, and they ranked 25 out of 29 hospitals. We also provide a relative improvement rate. A relative improvement measures the percent change, and we look at how much of a change occurred on a percentage basis between the 2013 baseline and the most recent quarter. So a decreasing readmission rate would mean that we're also seeing an improvement, and we would see a positive relative improvement. So, for example, taking a look again at the all-cause readmission rate, we can see that this facility had an increase from baseline. They went from 21.1% up to 23%. So since they didn't improve, we note this with a negative relative improvement, meaning that the readmissions from baseline to quarter 215 actually increased by 9%. And then on the flip side, we can look at AMI, which at baseline was 15.5% and went down to just 2%. And on a relative basis, that means that they had a 87.1% drop in AMI readmissions. And if you look just to the right of that, you see that they ranked 2 out of 27, and this means that the hospital had the second highest amount of improvement in AMI readmissions, leaving just one other facility that would have had a higher relative improvement of 87.1%. Okay. So if you have any questions, or like Maureen said, just feel free to jump in. I'm going to go ahead and proceed to the next page of our hospital report. And here we provide diagnosis information on what the most common diagnosis categories are on the index admission, which, as we know, is that first hospital visit. And then on the right side, we have what the diagnosis was when the patient was readmitted into the hospital. All diagnosis categories are based on the principal diagnosis code, and these are currently based off of ICD-9 codes, and soon we'll be switching over to ICD-10. And we are using the ARC, the AHRQ clinical classification software, which is very similar. If you're familiar with the DRG, it's kind of the same similar idea. It just groups several diagnosis codes into one category. I do want to point out that this report provides you a frequency count, and it's not a readmission rate that you see here. So for this example, the first diagnosis category is congestive heart failure, and for this facility, out of the 183 readmissions, 17 were originally in the hospital for CHF, and then you can see on the right, 23 patients came back to the hospital with CHF. One last thing to point out is that for this specific page of the diagnosis information, the categories on the left don't necessarily tie into the categories to the right. So the first one being CHF with 17 readmissions and CHF having 23 readmissions on the right side. The patients that had CHF that left the hospital may have came back with something else, such as COPD, sepsis. So that is not shown on this page of the report. But on our next page of the report, we do a top 10 index admission diagnosis categories with their associated readmission diagnosis categories. And so if we look at the example here, just looking at those first two rows, we can see cardiorespiratory failure had 3 readmissions with the same diagnosis. And then on that next row, we can see that they had 4 readmissions that were actually COPD. So you can use this report to really help pinpoint which diagnosis categories are driving your readmissions. We also provide you with information that shows whether the patient was readmitted back to your hospital or was readmitted to another hospital in the state or readmitted out of state. So that is our hospital report. And I'm just going to pause here and see if anybody has any questions or feedback that they'd like to provide.
Bonnie and Jeanette, are you good?
Good.
Is it helpful to see the reports that the hospitals are getting? Does it help you understand a little bit better how everything comes in, how everything connects together?
Yes.
Yes.
Okay, good. Good. And like I said, don't be shy. If you have questions. All right, go ahead, Blake.
Okay. All right. So the next report that we wanted to talk to you today was around our community report. And as part of the 11th Statement of Work, or CMS 11th Statement of Work, we're moving beyond the silos of our own 4 walls and building communities of providers who partner together to improve transitions of care for the patients that they share. So in these communities or coalitions, we provide reports that focus on the facilities, focus not only on the facilities, but rather the patient. The reports include utilization data about the patients who live in the zip code catchment area. And these reports include population-based measures on readmissions, admissions, ED utilization and observation utilization, and mortality. By using these community reports, coalitions can monitor the impact of their collective action. And let's just quickly stop here and take a look at what these community cohorts are. So the way this has been set up is that a certain set of zip codes compose a community, and multiple communities might make up an individual cohort. So for just focusing on Maine, the pink shade is the northern Maine community, and it's basically just all those zip codes that you see highlighted in pink, and that would be our cohort A. That was established back in 2014, and then just recently here in 2015, the green area you see right in the middle is our central Maine community, and just to the left of that in the bottom left is what we're considering as a possibility right now. The purple shades are not set in stone yet, so these are under consideration as our cohort C communities. So let's take a minute here to talk about the population-based readmission measure that we're looking at. The number of readmissions within a defined area of a state versus the total population within that area. So, for example, we look at the number of Medicare beneficiaries that were readmitted for every 1,000 Medicare beneficiaries. So I'm going to walk you through an example of this population-based readmission measure. So we're going to say that community ABC has a total of 25,156 Medicare fee-for-service beneficiaries that reside within this community. Of those 25,156 beneficiaries, 325 were readmitted to a hospital within 30 days of a previous hospital stay. And then we should just walk through the calculation, which is in the upper right section of the slide. You can see that we're dividing by 325, the total number of readmissions, divided by the total number of beneficiaries, which was 25,156. That gives us 0.1292, and then we just simply multiply that by 1,000 to measure of 12.92 readmissions per 1,000 Medicare beneficiaries. So we can just simply interpret it that in this community, approximately 13 out of every 1,000 Medicare beneficiaries were readmitted to a hospital within 30 days. So this is our community report, and as you can see at the top of this report are community data on all-cause readmissions and all-cause admissions. The three charts on the bottom cover ED visit, observation visit, and all-cause mortality. Coalitions can use this data to monitor trends that are occurring within their community and help gauge community performance. State and regional rates are provided as a comparison for each measure. And this is the second page of the community report, and like the hospital report, readmission data is examined within the community by specific diagnosis categories. So for here, we're looking at AMI, heart failure, pneumonia, and COPD. And again, coalitions can examine performance under specific diagnosis category to determine if there are any favorable or maybe unfavorable trends on a specific diagnosis category that are occurring within our community. And again, to help gauge performance, state and regional data are provided as a comparison. So again, I just want to emphasize a couple things about our report to talk about what it is and what else you would need, what it's not as well. So the data that we're using is not risk adjusted, and again, it is limited to only Medicare fee-for-service beneficiaries. However, one thing to point out is that hospitals are interested in this data as it relates to the value-based payment, and this also presents an opportunity for nursing facilities to present the value that they can provide within their community. Embracing and utilizing data can drive change to improve processes and resident outcomes, and while claims data has an inherent data lag, it is great for trending and combining with any facility-collected data as well. With that, I'm going to pause again and see if there are any feedback or questions around our community reports that you might want to talk about.
Any questions, guys? I know I sent these out to everybody before the call so you could have a chance to review them in case you did have any questions.
I don't have any questions at this time.
Well, Bonnie, you cover the entire state, correct?
Yes.
So these community reports, when you're looking at them, would be good just to gauge how facilities within these zip codes are doing. But the state reports would be better indicative of how facilities throughout the state are doing.
Correct.
Right. And for Steve and Jeanette, who both work in northern Maine, this just really gives you an at-a-glance view of, you know, how the northern Maine cohort is doing in comparison to the rest of the state and to New England. That's just the bottom line.
In looking at the map that you had up, is it really total state, or is it just in those areas with defined zip codes?
So, if you notice the pink, Blake just went back to the slide. If you notice the pink, that is the entire cohort that we agreed upon to be cohort A, and that pink area is all the zip codes that are participating in our Northern Maine Care Transitions Coalition, Steve.
Right. So it's Aroostook, Penobscot, Waldo, and Hancock?
Yeah, basically, it is that we didn't just, CMS doesn't have you do it by counties. They more do it by zip codes and hospital service areas. So that's how come it's like oddly shaped like that as well. And I'm not sure when you and I met if I showed you what the original suggestion looked like, but really when we first came to this job, CMS suggested that Northern Maine, the Northern Maine cohort, and it really was just the Bangor area. And so we, as a state team, negotiated covering further and all the way to Northern Maine to really encompass the true Northern Maine.
What my question is, in looking at that map and looking at the data, in comparison of the Northern Maine area, you said you can compare it to what it is statewide, and that's what I'm wondering. All of those unshaded areas, are those included in the statewide data?
Yes, they are.
Okay.
So if we let's jump back into the report real quick. So that green line is New England region, and the dashed line, the black dashed line, represents the whole entire state.
Okay, that's the question. It is the entire state. And New England region, is that the traditional New England states, or does New York get thrown in there?
No, it's not. No, it's just Maine, Vermont, New Hampshire, Massachusetts, Connecticut, and Rhode Island.
Okay.
Anything else?
All right, I'm going to hand the ball over to you, Maureen, and I'll hand it over to you and Rachel.
Perfect. Thank you so much.
Sure.
Okay, so now we're going to take a look at some data on adverse drug events. So just a little background, Institute of Medicine defines an adverse drug event as an injury resulting from medical intervention related to a drug. So this includes, but is not limited to, medication errors that cause harm, adverse drug reactions, allergic reactions, and overdoses. So ADEs occur across all care settings, and it's been estimated that they comprise about 1/3 of hospital adverse drug events, affecting approximately 2 million hospital stays annually and prolonging the length of stay from about 1.7 to 4.6 days. So in the outpatient setting, national surveillance data indicates that ADEs account for more than 3.5 million physician office visits, 1 million ED visits, and approximately 125,000 hospital admissions each year. And although data regarding the effect of ADEs during care transitions is lacking, it is estimated that they are among the top drivers for 30-day hospital readmissions. And older adults, especially those on high-risk meds, are far more vulnerable to ADEs. And the Department of Health and Human Services has identified anticoagulants, diabetic medications, and opioids as 3 of the most commonly implicated drug classes in adverse drug events, which is why we'll be focusing on these high-risk meds. So the next couple of slides are going to show you the quarterly scorecard for probable adverse drug events. And so these were not created by us. They were actually created by the NCC for CMS. So we're just showing you the data that they've put together for us. And so they used Part A and Part B claims data to determine a numerator, and the denominator was based on calendar year 2013 eligible high-risk medication fee-for-service beneficiaries. So this slide shows a bar graph of national and state-level probable adverse drug events per 1,000 fee-for-service high-risk medication beneficiaries from 2013, and it's stratified using drug class. And so a high-risk medication beneficiary is defined as a beneficiary using 3 or more prescription drugs, with at least one of those being an anticoagulant, an opioid, or a diabetic medication. So the NCC and CMS developed this methodology to identify these beneficiaries based on a combination of prescription drug utilization and high-risk medication use from the Part D claims. And they had the help of an advisory panel to define certain ICD-9 codes that indicate a probable adverse drug event within each drug class. So then they looked at Part A, inpatient hospital claims, and they determined these rates where probable adverse drug event ICD-9 codes exist in any of the diagnosis code positions in the claims and also in the principal, so the primary diagnosis code. And so looking at the graph, the dark blue bars represent probable adverse drug events for ICD-9 codes in any position in the claims data, whereas the light blue bars represent probable ADEs for ICD-9 codes in the principal diagnosis code position. And as you can see, the data is stratified by drug class, and for both Maine and national data, anticoagulants are responsible for the highest number of probable ADEs for any diagnosis code position and for the principal diagnosis code. So this makes sense when you think about all the factors that come into play with Coumadin dosing alone, and then add in other chronic conditions, medications, and socioeconomic factors. Another thing I wanted to mention looking at this slide is that Maine is below the national level for probable ADEs in all categories, with the exception of probable ADEs related to diabetic agents for the principal diagnosis code. So this may suggest the need for increased diabetic teaching across the state, which is one of the things that we're trying to do as a QIN-QIO, offering diabetic self-management program classes to the Medicare beneficiaries. Okay, so this slide shows the state ranking for probable adverse drug events for beneficiaries on anticoagulants. So it's a bar graph showing calendar year 2013 and the probable adverse drug events per 1,000 fee-for-service beneficiaries. So as you can see, we're in the 9th position, which is lower than the national average and better than the majority of the states in the nation. And so the rankings are based on rates in which the probable adverse drug event ICD-9 code exists in any of the diagnosis code positions. So it's not just an identified diagnosis code in the primary condition, or primary position, sorry. Okay, so this bar graph is very similar to the last one, but it's using the diabetic agent. So our rank is number 41, which is just above the national average, and obviously we're not doing quite as well as we are with the anticoagulants in terms of diabetic agents. Okay. And then the last slide is the same thing but showing beneficiaries on an opioid. So we're ranked number 8, and I actually would be interested in seeing how the rankings might have changed in light of our current opioid crisis in the state. I know that this information is from calendar year 2013, and just in 2014 and now in 2015, I know that we've had a lot more overdoses and deaths related to opioids. However, this is specifically for Medicare fee-for-service beneficiaries. However, it would be interesting to see if we moved up in terms of adverse drug events for this class. And so this is the last slide. We just want to give you a snapshot of the scorecards that we're starting to get from the NCC. So there are some limitations to these reports. When you're using claims data, obviously Blake talked about there being a 6-month lag. Another limitation is that the ADE rates are probable, they're not certain. So ADE screening has historically not been captured or monitored in a standard way, and therefore it's significantly underreported. So as a quality improvement organization here in New England, we're working to mitigate this concern in a few different ways. So that's a lot of the work that Maureen and myself have been doing with facilities and everybody else across the region. So we're trying to understand the current processes and data capture procedures. We're also trying to educate the providers about the value and feasibility of capturing this data, and we're also identifying surrogate measures until we have more comprehensive data capture. So that's looking at triggers within the hospital facility level. We're using the ICD-9 codes and, comparing it with the Part D claims. So we're leveraging the claims data to help increase the surveillance. So these reports are kind of a starting point for us with the ADE data. And like I said, we didn't actually create these. So we're hoping that in the near future we'll be able to create similar community reports to share that show more of the rates in your area. But we're working on that now and hoping that we'll be able to do that. So I just had a couple of questions. I know we don't have too many people on the call, but everybody's input is definitely helpful. So I was just wondering, looking at the data, does it surprise anybody? Or is this similar to what you would expect the trends to be looking like? If anybody wants to answer.
This is Steve. I just didn't see any. Yeah, I didn't see any surprises. So.
Thank you. Okay, great. And Steve, do you think that this type of information would be, these reports on a community level would be helpful or useful?
I do, and I'm just thinking of how we might, we meaning me, into some of the Help Good Maine partnership people. Some good stuff here for them.
Exactly. Jeanette and Bonnie, did you have any comments? Do you think that this information would be useful on a community level?
This is Jeanette. I do think that this would be very helpful at the community level, for sure.
I do as well.
Okay, great. So when we do figure out more about those reports, then we'll be able to reach out with you guys and give you that information. And Steve, at some point once we have this, we'd love to work with you and try to see how we can collaborate and give the information to the partnerships as well.
Okay.
Thank you.
Excellent. So we've come to the end of our presentation part, and I just wanted to check in and see how everybody was doing. If you feel like you have unanswered questions, was there information that you wanted covered that wasn't covered? I'm going to take that as everything was perfect. Was everything perfect?
I know for me, in being new, it's just real helpful information to have and to know where it's coming from.
Good.
The same for me.
Thanks, Jeanette.
Maureen, these slides, will they be available for the Northern Maine nursing homes?
They absolutely will. Following the webinar, after this ends, I will send out everybody information on how to access the presentation, and you can send that to your homes and your facilities.
Okay. If you have additional questions, and if there's additional questions afterwards, we'd be happy to address them on an individual basis as well.
Absolutely, but this really is a great opportunity while we have, these regional experts here with us to take advantage of that. And I like to play Stump the Analyst.
Morgan, I just put a link in chat that will take you directly to the events page on our website where you can download the presentation.
Perfect. You have that, Bonnie?
I do. Thank you.
All right. So, any other questions or discussions? Do you see ways in which your facilities can use this information to sort of use as a guideline in a way to see what trends are happening and focus on and take a look at where we should be focusing to prevent these admissions and readmissions.
Yeah, I can see where this can be very useful for me, so, in the work that this agency does.
Perfect. What about you, Jeanette?
Same thing. I think it would be very useful.
Good. I know that well, Bonnie and I have talked, and I do know that the nursing home facilities use the nursing home reports because I work closely with Sharon, and we definitely get a lot of feedback on the nursing home reports. But I also think this is a really good opportunity to sort of take a look at the other reports that are out there. And I know that that nobody on the phone is from the hospital facilities, but to be able to see how they all connect and what everybody else is sort of reporting on. So if there are no other questions, Blake or Lynn or Morgan, did you guys have any questions for the folks on the phone? How about I do that?
This is Blake, and I don't have any specific questions. I do think the ADE data is very interesting because I think it's not something that I've seen before. Since our National Coordinating Center put that analysis out, and I think it definitely can help at least create a conversation around ADEs, and I do think it's very interesting to look at.
I do also. Well, if nobody else has anything, I do not want to keep people longer than they need to be. I just have a few announcements. When you close out of the webinar, an evaluation will automatically pop up on your computer. We really use your evaluations to figure out where to go next and to help ourselves improve so that we can be of best service to all of you. Our whole job is to help you in the community and help reduce penalties and reduce admissions and readmissions. So please fill out your evaluation so that we can continue to provide you with useful information. If you don't have time to fill the evaluation right now or you're sharing your computer, an email tomorrow morning will arrive with the link to the evaluation as well as the link to the event page on our website. And the PowerPoint presentation will be posted within the next few business days. And I also just wanted to remind you, I have been sending you information about our next webinar, which is on January 28th. And if you haven't already registered, I hope that you're able to join us. That we'll take a look at high utilizers, which is something that affects all of us. So, and I also really wanted to thank all of you for taking time out of your busy days. I know that everybody here is busy, and I really want to thank you for spending the hour with us and participating, and for all the work that you do.
Thanks
Have a great day. Okay, take care.
Yeah, you too. Bye. Bye-bye.
Bye.